Hi, it's Patricia Coughlin again, and I wanted to kind of follow up on last week. We were talking about how important it is to distinguish between the defenses of externalization, transference, and projection. This is a small subset, in a sense, of being able to make the distinction between repressive defenses, which are largely intellectualizing defenses, minimizing, rationalizing, displacing, um, as opposed to regressive defenses like projection, dissociation, denial, somatization. Now, many of our patients have a real mix of these defenses and also what Davanloo called different lines of defense. So you might have a patient who comes in, minimizing, justifying, rationalizing their difficulties. Then as you begin to question those, well, you say a little bit, but it sounds like it was really a lot. Or, you laugh it off, but boy, that sounds actually pretty devastating. So as you begin to, in a sense, call into question their defenses, first of all, we're going to want to look at the response to see how syntonic or dystonic. And they say, oh God, you're right. It was really awful. Or do they begin to defend their defenses? Or thirdly, right, do they now go to their second line of defense? So once the first line of intellectualization is challenged, right, do they bring up now sort of a weepy, helpless position, right, as a second line? And then as you challenge that, do they get more regressed, right, and start kind of projecting, I don't know what you want from me, and this sort of thing. Now, again, why is it important, right, to identify and delineate these different layers of defense? Because Davanloo made a somewhat radical and really important shift in his work from the prevailing pathological view of patients, diagnosing them and identifying them by their weaknesses and difficulties, instead of by their potential or their highest level of capacity. And this is very crucial to being able to work at the patient's optimal speed. We want to be able to identify their highest level of capacity, and we're going to forge our alliance with that healthy part to address, right, the weak or unhealthy part. So we don't want to mistake the person and their capacity with their third line of regressive defenses. There is a huge difference between patients who only resort to those regressive defenses under a lot of pressure when their anxiety is really high versus someone who floods with anxiety and goes to projection almost instantly the minute they sit down with no pressure from you, right? In that case, you're really looking at someone that's the best they can do, and they've got a very fragile ego structure, as opposed to someone who's got the capacity to mentalize and to use higher level defenses, but regress under pressure, right? You don't want to confuse that second category with the first, and then treat someone who has greater capacity as fragile. So I hope this is clear that you're really wanting to identify that highest level of their functioning so that your aim is to work there and then to block regression in patients who have that tendency. And that's a very different procedure than trying to build up someone who can only use regressive defenses as in fact, more fragile. So I hope, again, this is helpful to you, right? That you're evaluating the first, second, and third line of defense and able to tell the difference between someone who has a lack of capacity and is truly fragile from someone who regresses under pressure. Again, they're two different sort of diagnostic categories, and you're going to respond to them differently. So again, please, give me your feedback, questions, comments, and we'll continue this conversation. Thanks.